welcome everybody to our renal cancer session. Before we start, I wanted to just apologize to those people who were involved in a previous live stream that was hacked, and it was pretty horrific, and we apologize. We obviously are mortified about what happened, and we hope that it never happens again. Brian, do you want to add anything to that?
Yeah, it won't happen again.
It won't happen again. Okay, that's the right answer. Yes, good. I wonder if we can introduce ourselves. Mike, firstly, I'd like to congratulate you. I know you've just won a Lifetime Achievement Awards for your work in immuno-oncology at SITC. Congratulations to you for that. I know it's been a huge amount of work over a long period of time. We must have met 20 years ago, and your work has continued with a number of different fields. And I just wanted to say congratulations for your huge contribution to the field. So congratulations, Mike.
So if I can just say just a minute, thank you very much. And as I said in my speech yesterday, that everything I've accomplished in my career has been as part of a team. And I've been really fortunate to be part of some great teams. And I could name all of them, but it'll take too much time. But the kidney cancer field is one of them.
Brian, David, Tony, introduce yourself.
Brian, Rini, and I've won no notable awards recently.
David McDermott, Beth Israel in Boston.
Tony Choueiri, Dana-Farber, also in Boston.
Let's kick off to start with. We had an update. We're going to talk about frontline kidney cancer. I think we disagree on a number of issues, and so we might as well get them on the table early.
Sure.
We had some data from China with a combination of toripalimab, which is a PD-1 inhibitor being developed in Asia-Pacific region, and in combination with axitinib. And it's come in again with great data, an OS hazard ratio of 0.61, 40% reduction in the risk of death. Does this not just reinforce to us the importance of VEGF-TKI IO therapy up front? Is this just not more armamentarian to put in our, how many times do we need to show this? How many times do we need to do this? David?
We're over whatever the limit was. We're over the limit. But I think the study's important because this will bring PD-1 therapy to the front line in China, where the kidney cancer problem impacts an enormous number of patients. So for that, it's a good thing.
But you don't think it changes the debate at all?
It's essentially early axi-pembro data. It will not improve with time. It will look less good. If we look at it 3 years from now, it'll look less good, just like...
In your opinion, you feel that's the case?
Just based on the facts, yes.
There may be less access to subsequent therapy in China, and then maybe if there's less subsequent therapy, it may actually continue with these data. Is that possible, or is that impossible?
It's possible.
Excellent.
It is possible, but still, your curves are going to have sagging problems for the combo arm. You have saggy curves on your trials. That will continue.
We're going to keep the word sagging in our mind because we've got some sagging data for Ipi-Nivo to show you later on as well.
Good, bring it on.
Excellent, we're going to do that.
I feel like we're being set up here.
Mike, if you win a big award,
We're being set up, but I've got some secret weapons.
I'm looking forward to those secret weapons. So here we go. After seeing this data, assuming you had access to both, which would you choose? And axi-pembro seems to be the standard. I mean, Tony, we don't have to talk about this for too long a period of time. I think, do you agree with David? It's a contribution, but it's not changed things too much.
No, I agree. I think the biggest message here, and I'm glad ESMO picked this as an oral presentation, was one, discussant, because ESMO is a global society, and to my knowledge, at least to the knowledge of the discussant too, there was no PD-1 approved in China. So I think this was very important. The discussion by Dr. Van der Veld, Astrid Van der Veld, was phenomenal. She put this in a global context, and I think that is the message rather than interchangeability with axi-pembro.
This is a key slide, I think. Although it's actually ASCO data, not ESMO data, it does give us some update. And Meredith Regan has helped many of us on the panel interpret these data, and we've debated them with Mike and others And I guess it comes to this point around the OS hazard ratios and what we think overall about the evolution of these trials. And I guess the key issue comes to the OS curves and whether they're crossing associated with VEGF-TKI-IO and whether or not that's the case with Ipi-Nivo. And I think it's fair to say that the initial data for the VEGF-TKI-IO combinations was better than Ipi-Nivo. I think when the first 426 trial came out with hazard ratio 0.53 for OS, 63% response rates, PFS of well over a year, I think it was 2 years, it was 15 or 16 months, 16 months.
That's right,
I think most of us agreed that was the case. As time has gone by, Brian, because you've led a number of these trials, and Tony, I'd like you to answer this too, do you think the VEGF-TKI-IO data has become less impressive?
I mean, I think what's impressive about IO-TKI is the early effects, right? It's limited PD as best response, its response rates, its PFS, its tumor shrinkage endpoints, as David would say. So those haven't really changed, right? I mean, those numbers, these are the updated numbers, but they're in essence identical to what you presented X number of years ago, whenever that was. So I don't think that the strength of this regimen hasn't changed. And I do think it's important to have now 5-year and 4-year follow-up respectively for these trials, and we need more. Right, I do think there's a tail of the curve, right? Mike and I might debate that, but in reality, we just need a little bit more, right? We have some good follow-up data, but we still need more.
Mike, we've dragged you all the way here from Washington, and we've got this slide for you. I know you feel strongly about this. What do you think is going on?
Well, I certainly agree that the early endpoints of PFS and response rate are better with IO-TKI. They should be, because you're giving your first and your second line therapy together. But that's really not what patients care about for the most part. If you look at what patients care about, they would, number one, want to have their disease go away and get back to their pre-cancer lives. And even though you may think there's a tail on that curve for Axi-Pembro, those patients are still on axitinib. And as quoting Susan Poteet from yesterday at SITC, where I ran into her, she said, gosh, those patients who are still on axitinib, they tell me it's just like being in jail for long-term anti-VEGF therapy. And so what patients want is to be able to stop therapy. And until you show me that there really is a plateau when you stop treatment, I'm going to say you're not curing anybody, and you've lost the chance to cure people when you've given them IO-TKI as their first therapy.
So, Mike, one of the things that I've always pushed back on with you, I think, is that I don't think our drugs are good enough yet. So I don't think Ipi-Nivo is good enough to say we're curing enough patients. And I think that some of the pushback has been that actually if we were curing 70% of patients like testis cancer, then that would be great, but Ipi-Nivo is not BEP chemotherapy. And I think we'd all agree on that.
I will say we're not curing enough people,
Yes.
And the best way to cure more people is to build
Better
on
drugs.
a pure IO backbone, because you cannot build on an
So if our
IO-TKI
drugs-
backbone, because you cannot give full immunotherapy when you're making the tumor acutely hypoxic.
If our drugs aren't good enough, and we agree they aren't, then initial control of disease is important. Because when patients come and see me, I think one of the things they
I
want...
disagree completely.
So-
it's important for some patients.
Yes.
But for most patients, they don't need to have an initial control of their disease. They need a chance at cure. And then if they're not cured, they can get a TKI. And we know from things like CONTACT-3, they can still benefit very well from a TKI in the second line. So when you compare first line, second line combination to first line approach alone, that's an unfair comparison.
Tony and David, let's have this debate now, because this is important. Do you agree that the drugs aren't good enough, Ipi-Nivo's not BEP, and therefore, because we're not getting enough cures, initial control is really important, which is my position? Or do you think Mike's position, which is actually that because we are curing some patients, that initial control isn't relevant? two different positions.
No, I mean, I think initial control is relevant, but not every patient, need absolutely initial control. I think it's fine to build on nivolumab, ipilimumab, totally fine. And so far, the first attempt adding cabozantinib, maybe this is not the drug, but what other drug there is in IO and why people have not or are not trying it. We're all trying to talk to folks to do those type of studies. But the bottom line, not everyone, you don't need to drop PD to 0. Great if you can, but there are folks where, if the CR rates are very high, let's say a regimen that give you 30% CR, even if the PD rate is 30–40%, as long as the disease is not exploding and you can have a second line, I'm okay with that. But I don't know who and what, and the biomarkers are up in the air.
Same question to you, David. It's this issue that was the thing that caused the discussion post-ASCO. Is initial control important, or is ipi-nivo so good that it has to prioritize everything else?
Well, the problem with this discussion is not the data, because the data backs up what Mike has been saying. He was saying it several years ago. He predicted what was going to happen to the curves.
We're going to come to the shape of the curve in a second.
I understand, but your curves,
because not everyone
getting
agrees.
back to the curve, the point is he said 3 years ago what the curves would look like now, and they do. Because if there's an IO effect, we've seen this for decades, the effects get better with time. Because in a subset of patients, you eliminate all cancer, and patients live in remission, and some of them are cured. So to me, this debate is interesting. I love being with you guys. This is great. Nashville is awesome. But it's kind of a waste of time because what we've proven, no, we're never going to convince. Tom has been saying the same thing for he's very somewhat repetitive.
So I've changed
but
my
point is
position.
I am not finished my sentence. I'm getting there. I'm getting there. The more important question is, do you believe kidney cancer is curable, yes or no? And if the answer to that is yes, then our first priority, not our only one, should be how do we increase the cure rate of patients with advanced kidney cancer? So do you believe that? Yes or no? Can you cure a patient with metastatic disease?
Yes.
You got one yes. I want to answer the question.
I'd like to say we can cure some patients. I'd also like to say my position actually has changed. And I'd put my hand up and say, well, mine has. Unlike other people on the panel, I've moved my position. And mine has shifted because I'm even comfortable now with ipi-nivo and good risk disease, dare I say it.
Hold
on, we're going to come to that. But my position has changed. I think there's genuine equipoise between the two. I have been critical of people.
I'm so glad you're moving in the right direction.
So my position has changed from
I'll
saying...
let you know when you actually made it.
I'm never going to get there.
Right,
I'm never going to reach the promised land. So my position has changed from VEGF-TK IO for everyone to I'm very happy with actually both regimes being in a similar position. I can see advantages and disadvantages of both approaches. So when you say my position is the same, that's not true. It actually has shifted. But the issue...
Well, I'm just learning your new positions
No, my
today.
position...
I'm really glad that I showed up
If
for
you
this.
listen to our podcast, my position has always been that. I've been comfortable with both approaches. And actually, the question, though, you come to is the landmark OS. And so if you look at the landmark OS in these trials, 60% landmark OS at 3 years, 63%, 59%, 66%. So this sort of saying that this saggy piece around VEGF-TKI was not supported by that data. That's something that's been plucked out of the sky.
Do you want to take that, what he's talking about?
Because landmark OS is important.
Landmark OS is important, but landmark PFS is a better measure of the effect of the first-line therapy.
Excellent. So let's go on to landmark PFS, because this is important, and we've had this discussion before. And one of the concerns about about PFS, generally speaking, is PFS is good for a year, because patients are compliant and they take part. It's good for 2 years, because they continue to take part, maybe. But after 2 years, PFS is not a useful endpoint. Is that fair, Tony, Brian? Tell me about that.
No.
No, that's ridiculous.
What is that? That's,
I think we all think that's
what,
ridiculous.
yeah, no. I think
So when you've got censoring of more than 50% of patients, you've lost more than half the patients.
PFS is really important when the patient has stopped treatment and they have a
Not if they're not
plateau
having their scans
on their
done.
PFS.
But that's only if they're having their scans done. If they're no longer having their scans done, they've moved from a different hospital and they're enjoying their lives and they're not having their PFS, that trial becomes less robust. And robust endpoints are dependent on the robustness of the endpoints, and censoring that is a concern.
Are you criticizing 214 because all those patients were
I'm
followed?
criticizing long-term PFS in
All those
studies.
patients were followed out to 5 years.
No, many were. So there's lots of censoring on those curves. And there is censoring on the curves, Brian, you know this.
Thanks for pulling me into
Yes.
this, Tom. All right, let's back up. We're talking about a lot of different things here. Can patients with metastatic RCC be cured? Absolutely, right? And that's why I pushed the bladder panel, right? I think the same is true for bladder. And we have to stop shying away from that word, right? Patients can be cured. We may not know what the fraction is, and we have different definitions, and et cetera, but I think patients can be cured. And I totally agree from an investigative standpoint. If you said we need to build on IO if we're prioritizing cure, then Ipi-Nivo plus drug X is a great design, or whatever. We can come up with different designs. I totally agree with that. As we've said, IO-TKI strength is disease control up front, and even if, on a survey, the patient preference, the top ones to be cured, unfortunately, many people walking into clinic, they don't get that choice, right? They do need disease control. I don't know what that number is, right? And we can debate symptomatic disease and bulky disease. We can debate those definitions, but it is a substantial fraction, even at a tertiary care center, let alone in the community, and Chandler's here can comment, So I think a lot of patients, either they can't tolerate Ipi, or they need a response. They can't afford progression. I think that's a substantial fraction of patients.
So coming back to the censoring issue, which is causing discussion, long-term censoring.
Trying to ignore the censoring.
It's important.
issue.
It's important. We have to, because if you believe the long-term PFS data of Ipi-Nivo, and you say that this is a very robust endpoint, we believe the shape of the curves. No one's questioning that. And Meredith was very clear to us. She said you shouldn't question the curves. The curves are the curves. But she did say you need to look. As time goes by, PFS is not a great endpoint because there comes a point when it's hard to follow PFS robustly on patients.
Well, I think if your point is that there's more uncertainty in that curve the farther you go out,
Yes.
that's true. Right?
Okay.
It's true for every curve.
That's true.
And if we're trying to compare censoring of 214 versus 426, et cetera, we don't have the numbers. I don't know that data is publicly
Yes.
available and comparable.
I didn't say one was better than the other.
So let me just clarify something. When you were talking about sagging curves,
I think that was David.
OS in 214 will sag because some patients have progressed and they're on TKIs, and at some point the TKIs stop working, just like they have done in the first line, and the patients die. So those patients who are on those overall survival curves, some of them are not cured and they're still taking therapy. PFS is a better measure of the stability and the durability of an immune therapy response compared to OS in that regard. But OS is a much more important curve because it measures first-line therapy with the best immunotherapy you can get now, plus, at least in modern data, which we didn't have with 214 because there weren't all these TKIs available, plus second-line TKIs.
Tony, Mike and David are saying that the OS curve for the CLEAR trial, I think you led that study, those curves are coming together, and that the hazard ratio is drifting from what was in the 0.6s to now the late 0.7s, and that those curves are coming together, and that's an indicator that actually the VEGF TKI in the end is a problem. What is your interpretation of those curves? Do you think they're coming together, and do you think they're saggy?
I think they're coming together. I'm not too happy about it. I think the 95 confidence interval with pembro-axi-pembrolizumab is 0.99. Yes, this is, the statement is these two studies are positive for OS, period. But the durability of responses and survival, I don't like that. When you have Nivo-Ipi at 5 years and hopefully more, durable with a hazard ratio that has not moved beyond, less than 0.7. The one thing I just want to add that we don't have the same follow-up with 9ER. Hopefully it will come soon. And it will be the third thing. If it's still drifting, if the confidence interval of 0.99, that is a statement.
David, we did a podcast with Bob Motzer, actually. Bob came in, and I thought it was very, I mean, he was coherent, which
I would hope so.
he was very coherent. And he was, compared to, I felt, you know, some of our discussion was quite, you know, it was quite noisy. Whereas I thought Bob was very coherent. And what he essentially said was you've got 4 big trials. They're all positive. There are more similarities than differences. And this discussion around the end of the curve is actually counterproductive because it's distracting from more important issues like how do you give the drug safely up front, how do you make sure you're getting the drugs in correctly, and actually, therefore, interchangeable choices. And you shouldn't get too caught up in this debate that you're having. And in fact, I think that's, you know, that's his coherent statement is this discussion, as you said, how helpful is it? Do you actually agree with Bob that these are all very similar? We've got 4 positive trials, and this comparing the tails of curves in cross trials is actually a complete waste of time. And this whole debate, therefore, we should just walk away from.
Well, I agree that we should walk away from it. I'm trying hard
I keep dragging
to
you
walk
back.
away from it. Yeah, but for different reasons. And the
But you
reason
use
I-
words like saggy, and when you use words like saggy, you can't help but bring me back in. If you said to me, no, I agree with Bob, I heard his podcast, he's right, then
know
we
he's
wouldn't be here.
not.
But you can't do that. You have to keep coming back.
Without using names, to say that long-term endpoints are not important is hard to
He
defend.
didn't say the long-term endpoints, the
that's
trials
what-
weren't important. He's saying comparing the long-term
But
endpoint
the
to 4
long-term
trials is not
endpoints,
important.
it's not so much about comparing the trials. It's comparing the experimental arms to sunitinib in all of the trials, and they all do the same thing. And to me, that's disappointing. I mean, I often get asked to defend Ipi-Nivo, but I was there, I think, early on when VEGF PD-1 was the thing we were going to do, right, to make PD-1 better, because PD-1 alone in kidney cancer is not good enough. We were trying to enhance the immune response to the tumor. And what I think the sagging curves show, and the lack of plateau shows, and the inability to stop treatment in most patients shows all the same thing, which is VEGF blockade does not enhance the immune response to the tumor enough, certainly as much as we had hoped, as much as the preclinical models had suggested, as much as they've seen in other tumor types like hepatocellular cancer. What we did, we were all there, and that part, it didn't work out so great, and we should just admit it and say going forward, well, what are we gonna build on going forward? What are the control arms going forward? I think those, at least in the front line, they should be IO. They don't have to be Ipi-Nivo, but they should be IO. And, right? Who's gonna disagree with me?
Brian.
No, I'm not going to disagree. I'm
Good.
just going to make sure David doesn't leave. But I think you're right. I think we all, and in fact, the first time I heard somebody talk about combining immunotherapy and VEGF was the person to my right at an ad board probably, I don't know, 10, 12 years ago. You were begging them to do it. So it's kind of your fault, right? I mean, all these trials in this debate.
Were
it's
you
kind of
wrong,
your
David? Because
fault.
some of your early data showed that infiltration of immune
But
therapy
I agree.
associated with VEGF targeted therapy.
Right. No, we thought we were on the right track. We thought that there's a great study by Genentech with atezobev in the early days in serial biopsies. We thought we were bringing T cells into the tumor that weren't there before. But and maybe that happens in some patients. It's just not enough. And I think when we get to a more interesting part of this discussion, like what's happening with favorable risk patients, it's at least conceivable that some favorable risk patients, if the goal is long-term benefit, are harmed by persistent VEGF blockade.
And I'll just add, as a confession, that I led the phase 1 Axi-Pembro
I was in the
trial.
audience. I was in the audience.
And
Yeah.
I thought
I
that
was
was going to be great data,
Yeah.
except when I stopped the exitinib, everybody progressed.
Let's talk about let's talk about 914. So 914, we just recently heard that 564 single agent Pembro has a survival advantage on a press release, and we know this is the survival curve from 914. This is Ipi-Nivo. If Ipi was important, you'd expect something here, wouldn't you?
It's hard to say in melanoma, where Ipi really is, you know, verified to be important. In the adjuvant setting, adding Ipi to Nivo added nothing.
Does this help your argument, David, for Ipi-Nivo, or does it make it more difficult?
It makes it more difficult, and 8Y8 in the future may make it more difficult. But the
Describe
other,
8Y8, please, for the audience.
which is Nivo, PD-1 versus PD-1 CTLA-4. the next slide, otherwise called the next slide.
These are great slides.
These are awesome slides. Pretty colors, too. I like it.
David, don't get distracted.
But the trial that you should be showing, and we could be talking about because it's contemporary with this, is Cosmic 313, which is the world's best ipi-nivo trial in kidney cancer in a worse population of patients.
So let's talk about it right now.
Bring it on.
Show what does Cosmic 313 show, and why does that suggest, unlike the 914 study, why does Cosmic 313 show that ipi-nivo is a good treatment for clear cell renal cancer patients?
Okay, so it's PD-1 CTLA-4 versus the triplet with cabo, a very well done, executed study, a study we needed to do. The hope was that you were going to see not just better early endpoints, which you do, higher response rate, better median PFS, but by adding cabo, you'd also enhance the immune response that you see with ipi-nivo, and you don't see that. We don't see overall survival. We'll probably, prediction, never will.
We're going to come to that in a second.
Okay, but what you do see are a lot of deep responses on the ipi-nivo arm, and in part because they gave ipi-nivo, and that study, which is kind of ironical, better than we did in Checkmate 214, because in Checkmate 214, if you didn't get all 4 doses of induction, you couldn't get maintenance. In Cosmic, you could. So you see duration of benefit, you see depth of benefit. There are more, in my opinion, more CRs on that waterfall plot for Cosmic 313 than in the triplet. So that's a good study. And in a population of patients who have more primaries in place, a worse group of patients.
So
if AY8 is negative, I will be saying, look at Cosmic 313.
I'm going to come to AY8 in a minute, but I'd like to do Cosmic 313 first. So let's go to Cosmic 313. David's just said he thought the ipi-nivo arm, in some endpoints, actually outperformed the triplet arm. Number one, Tony. He said there were more CRs, he thought, on the waterfall plot. Do you think that's true? And what do you think, and he also said that Cosmic 313, he doesn't feel it's going to show survival. You put that study in the New England Journal of Medicine. I guess you know about it. You don't know anything that we don't know. What's your take on Cosmic 313? Does it support the position of ipi-nivo in the same way as 914 takes away from its position?
It does support it. It supports 214. The CR rate were less, and the simple reason is that way less patient had primary, way more patient had primary.
It was less overall the whole population.
Right, but I can see what David is saying in terms of deep responses, yes.
Do you think there were more deep responses for the ipi-nivo?
I think there were more deep responses, and I think we knew how to give 214 because we knew how to give nivo-ipi way better than 214. So we optimized it. We didn't take patient off therapy.
The toxicity was higher.
What?
The toxicity was higher for the triplet.
So the toxicity was higher with a cabo 40, even. So that puts in question, everything that we should or not combine with nivo-ipi. Nivo-ipi could be great. The question is it combinable? And it's not the nivo. We know it's not the nivo. It's the ipi. Is ipi a bad partner?
And what's the answer to that question?
I want to defer to Mike because I discussed back and forth a lot with Mike, and there are some times, depending what time of the day I ask him, and he would nod and say, well, maybe. I don't know, Mike.
I think that IPI, and we're looking at the 8Y8 schema, I think IPI will add some to nivo. It probably won't be statistically significant difference if the study ever accomplishes the number of events.
This is
it's a little bit
ipi-nivo
underpowered.
versus nivo. It's
Right.
a randomized trial.
Yeah.
I think
Small.
it's 300 or 400
I think there'll
patients.
be a clinically meaningful difference in the tail of the curve, but probably not a statistically significant difference. And I think there are better drugs than IPI that we might be able to
Right.
combine
That's the hope.
with anti-PD-1 to enhance the
But
immune
Mike, so let's double
response.
down on this. If IPI's not adding that much, are you saying actually just and Pembro's got a survival signal in the frontline setting and ipi-nivo, it's not frontline, in the adjuvant setting, ipi-nivo doesn't. Are you saying actually you think the single agent PD-1 therapy
No.
is the right answer?
No, I'm saying there are better drugs than IPI that we can add to anti-PD-1 in the future, and we shouldn't let IO TKIs interfere with our ability to study those.
Now, you talked about some new armory coming from your argument from your SITC meeting. Is now the opportunity to introduce those new drugs? Is that, do you want to talk about some of these new weapons?
I'm going to step back before SITC and say that we should look at LAG-3. Certainly some data to suggest that if you have more checkpoints expressed on your T cells, the less ability you are to respond to immune therapy, and blocking LAG-3 may be useful.
Is that in doublets or triplets, Mike?
Doublets or triplets.
Okay.
We need to look at both.
Yeah. And would it be a tragedy if we didn't do those trials?
Right, and it'd be bad if we looked at them with a TKI in the middle or belzutifan in the middle. We should just look at them and see what happens with pure immunotherapies in the front line and see what works better and see if we can find something that looks better than Ipi-Nivo and have Ipi-Nivo be the control arm of those studies.
And what else?
There are better CTLA-4 blockers. I think the botensilimab from Agenus has some properties that make it look like it's better than ipilimumab with activity in MSS stable colon cancer that we don't see at all with
What about the AZ bispecific?
Ipi-Nivo.
The AZ bispecific.
I don't think so.
So I want to
There are other ones, but go ahead.
I agree and disagree with Mike on these two things. I agree CTLA-4 depleters could be, better. We've seen the data in colorectal cancer. It's beautiful. I don't know if they are less toxic. I would say maybe not than Ipi, and that will be a problem for combination. Nevertheless, Mike is, leading the field with a study with another Mike and Mike, although the Mike and Mike showed got canceled, but we have a Mike and Mike Atkins and Mike Surzan from our group that are leading a study of Nivo-Ipi versus Nivo plus the CTLA-4 depleter using the HCRN mechanism, a smaller randomized phase 2.
Brian.
I just want to say, I think one of the arguments for IOTK is these high response rates and early disease control. If we had all immune regimens that had 60-70% response rates and long PFS, then a lot of that argument goes away, right? And if that's Ipi-Nivo, LAG-3, or whatever, or the Agenus product, then I think it's a very different conversation.
Right.
Let's move to this favorable risk population. So what's happened is we've got this classification that we used. It was originally adopted as a prognostic classification for VEGF-targeted therapy.
Mike came up with this classification, just to be clear.
So it was Mike's idea, apparently. And that classification, we call it the Mike classification rather than the Hen classification. That classification we used and then was suddenly got adopted to select patients for Ipi-Nivo. And now we are left with the favorable risk population, which initially we said, okay, well, they can get VEGF-TKIO. And then the VEGF-TKIO data has come out recently and is showing that it's not better from a survival perspective, not from a response perspective, not from a PFS perspective, but from a survival perspective, the hazard ratios are coming in at about 1. And so the question now is, do we need to change our thinking around the good risk patients? And does the IMDC classification have any role to play in this disease? David, would you like to start?
Yeah, I think IMDC is a very important effort. It needs to continue. Its focus needs to be on how patients are doing in the real world, which has been very helpful to us, and on survival prognosis, but it has absolutely no role in predicting outcomes based on these trials and shouldn't be used for clinical decision-making, period. So we should, just in general, because it doesn't predict the endpoints that the patients care about the most, which is long-term outcomes.
Brian, we have got ourselves caught in this good risk population. What's your standard of care in good risk disease now?
I still give IOTK. I totally agree that there's a subset that's immune responsive, Ipi-Nivo responsive. We know that from the RNA expression data. Again, we don't have the tools to select that, but I agree with what David said, that I think we put ourselves into this corner of IMDC, and Checkmate put itself into that corner, right, by the way the study was conducted, and now maybe trying to rethink that. So I think we need to get away from that. Right? I think the more we get away from that, maybe the more we'll agree on how to approach patients.
Right, because it was based on decisions made by industry to get endpoints faster.
That was the original trial design.
Correct. So
But-
we shouldn't hold patients responsible for those kind of decisions, which future patients.
But the
had nothing to do
original
with.
Ipi-Nivo data wasn't great in favorable risk. The hazard ratio was 1.6 for survival, the response rate was lower, and the PFS was shorter. So that was a logical decision at the time. And now that things have evolved since then, but it's very easy to be critical of the past. But I look back on the past, and at one point, you can see the primary endpoint was intermediate and poor. It was then an ITT recycled endpoint, so it was positive in an ITT population. It was never positive in a favorable risk population.
Well-
And the decisions at the time were logical. I don't think they were as cynical as you made out.
I didn't say cynical.
Right.
Okay. I wasn't saying cynical. They were done for a reason, to get quicker answers for the study. We all want drugs, we all want trials to be positive. We all want drugs out there sooner. I just don't think we shouldn't hold, now that we have new information, we, as you are doing, which is awesome, change our opinions. So now that we have long-term information about this, we move on. We don't talk about.
Tony, I want
We
to
don't-
go from
Please
one
go.
through the panel, one at a time, if I may. Just very quickly, the IMDC classification, should it be used to select patients for therapy in clear cell renal cancer in the first-line setting? Yes or no?
Yes, absolutely, and that's my algorithm.
And which decision do you make based off the IMDC classification?
So I mean, I gave talk at ESMO, every year how I manage metastatic RCC, but I think, in favorable risk, again, you can do whatever you want, although I agree with Brian. I accepted IO-TKI despite the hazard ratio for OS. And if it's intermediate or poor, I base my decision on needing a response, yes or no. This is outside the sarcomatoid, the 10% where Nivo-Ipi is standard. Now, if every patient that doesn't need an immediate response, is it wrong to ditch the IMDC risk group and give them Nivo-Ipi? Is that malpractice? Absolutely not.
David, the IMDC classification, do we keep it or do we stop it?
As I've said twice, we get rid of it.
Brian?
No, can I just make
yes,
one
of course,
point?
yes.
Because if you want to keep it, I want to get rid of it because I don't want patients to be punished for our past bad ideas.
Punish is a hard word.
Or, all right, we'll come up with a better word.
Yeah.
Limited, how about that? But if you're going to use it, well, all right, let's do that. Let's use it, and in good risk, payers could say, ex-US, well, I'm not paying for PD-1 VEGF up front because it doesn't impact survival. Why not just pay for the sequence? So if we're going to play this, well, let's go all the way, and let's advocate for the removal of some of these guidelines for good risk patients with PD-1 VEGF.
Brian?
I agree. We should get away from
Get rid of
using
it.
Yeah.
Mike?
Shouldn't use it for patient selection.
Okay, so
But can I
yes,
fill
please.
in some of the things on that last table?
Do you want to go back when it's called to count?
Yeah. So update HCRN for favorable risk. The landmark overall survival at 3 years is 97%. And the landmark PFS at 3 years is 31%. And
That's
so,
single agent Nivo.
what?
That's single agent Nivo, is that right?
Single agent Nivo.
And I did
So-
ask you the question before.
So the reason why the overall survival is 97% and the PFS is 31% is because the study was done in the United States only at academic medical centers, and every patient with favorable risk, if they did progress, was able to get second and third line therapies that weren't available in Checkmate 214. And so Checkmate 214 is unfortunate that it was done at a time when we weren't comfortable, the people giving it weren't comfortable giving Ipi-Nivo, and where there weren't the same type of follow-up treatments for those patients that exist now. And as a consequence, we saw 25% of favorable risk patients dead at 3 years, and that shouldn't happen in a favorable risk population.
I don't disagree with that. I mean, if you look at Nivo versus Pembra, I know they're different trials, but do you agree that the Nivo results in favorable risk in your trial, and again, small subsets, are exceptional right? And they stand in contradistinction to the Pembro. And if you just look at response rate, CR, and primary PD, which have nothing to do with subsequent therapy, they're different, right? I guess that, I think Nivo's as good as it gets in favorable risk.
Yes.
Yeah.
Right, but I would say Nivo appeared to be worse in the intermediate and poor risk patients than Pembro, and if you put the whole population together and don't deal with IMDC, then there's a 35% response rate with either Pembro or Nivo. And doesn't matter which category they happen to fall in.
So Mike, when I said to you earlier on, single agent Nivo, and you said, no, you would prefer Ipi-Nivo, but you said you don't love Ipi, why, with these exceptional results, why are you not more supportive of single agent PD-1 therapy? And I get the impression that your position is mainly you just don't like the addition of VEGF TKI because you think it's counterproductive, and you don't feel super strongly about the immune therapy you come up front with. Is that a fair statement?
I think it's a fair statement to say that single-agent anti-PD-1 is a good backbone to build on with combinations, and I would prefer those combinations be immunotherapies rather than TKIs because TKIs cause acute hypoxia in the tumor microenvironment, which, if you were at SITC, you would know that damages the immune response and exactly what we see happening.
But there is also
patients.
preclinical data to show VEGF-targeted therapy associated with T-cell trafficking, and there's data outside of kidney cancer with hepatocellular cancer where bevacizumab and atezolizumab is the standard of care. So it is working somewhere, and in other tumor types, they're actually really keen on that combination, where Ipi-Nivo hasn't come in a home run.
Well, let me just say that in kidney cancer, it's different because those tumors are not hypoxic, particularly the favorable risk or the high angiogenic tumors. They have high angiogenesis not because of hypoxia, but because they're VHL null, and the tumors do not get hypoxic until they're exposed to a TKI. And then you can't fully activate the immune system. If you'd been at SITC, you'd also know that the first 2 weeks of therapy are critical for producing the durable benefit.
Let's move to sarcomatoid disease quickly. So people like to give Ipi-Nivo for sarcomatoid disease, but actually the hazard ratios for all 4 combinations look very similar to one another. This again is your slide, Brian. What do you think about this slide as you were making it?
I think what stood out to me is despite similar hazard ratios, the follow-up for Ipi-Nivo is so much more. We haven't seen follow-up. So I think it's apples and oranges, right? It's central review, it's long follow-up, so I use Ipi-Nivo and sarcomatoid for this reason. And maybe with longer follow-up, et cetera, but I don't think so.
Tony, do you feel that all 4 regimes are interchangeable again, sarcomatoid disease?
No, sarcomatoid has to be Nivo-Ipi. Now we have 3 other preclinical evidence from our group why it should be Nivo-Ipi, why those tumors are hot, both genomically, at the protein level, at the RNA level, and most important recently was the work of Sylvain Baca, Matt Friedman, and several of our postdocs, how even at the epigenome level, they're hot. So Nivo-Ipi is the standard. What we have not agreed on, and is the percentage of sarcomatoid. And the fact is that usually when we have a tumor that is like 15% sarcomatoid and you have a metastatic disease, 2 years later, what do you do? What do you check? But there is no doubt in my mind when you call it sarcomatoid, Nivo-Ipi is the standard.
This is the latest frontline randomized trial. It's a study, a 3-arm study. It's got a pembrolizumab lenvatinib control arm with response rates of 70%, PFS of 24 months, with landmark OS very similar to all of the other studies. We've got 2 study arms in here. We've got a pembro CTLA-4 in combination with lenvatinib, and we've got belzutifan, pembrolizumab, lenvatinib. So the addition of belzutifan or the addition of CTLA-4 essentially. Predicting the results of this study, who wants to start? David, perhaps you.
So it's a very high bar with pembro-len to win on early endpoints because those are so impressive with that combo. So to me, that means that the CTLA-4 combo is almost certainly going to be negative. compared to pembrolizumab. It's not going to win on PFS, and it won't win on OS either because of subsequent therapies. It's possible, and Tony presented this data a couple weeks ago at ESMO, that early HIF inhibition can add to Lenva in a meaningful way. That, in patients who are VEGF naive, I'd like to see HIF moved up closer to the front line. If it was up to me, it would be as a single agent, not as a triplet, but it's not up to me, as we've discussed multiple times in this weekend. So that arm could win on early endpoints, but it's not going to improve the immune response to the tumor, and therefore you're going to still need to be on therapy. You're not going to see treatment-free intervals, and long-term survival will be identical.
Anyone else want to say anything on this trial, or can we close this session?
I just want to add that the resistance to lenvatinib is angiogenic escape. Part of that is driven by upregulation of HIF-2 alpha, particularly in tumors that have lost HIF-1 alpha. And so I think that belzutifan may delay angiogenic escape from lenvatinib and be a better longer hypoxia in the tumor microenvironment, which is great for lenvatinib activity, but means you'll see very little pembro effect in that arm. And this is a study, 4 studies where we're going to learn something, but I don't like any arm in the whole study.
Not keen on any arm. Brian, I know you're very involved in the trial.
Great way to end this.
Do you want to just
I'm a little more positive than that. I agree with, I think, what Dave was said about the early endpoints for Belzu. I think we all want to see it up front, and some of the combo data, at least in the front line, is exciting. I'm more positive that the CTLA-4 arm can improve survival, because I thought you said early CTLA-4 improves survival. That's what I'm
Unless you're giving
confused
VEGF.
about. I see. Okay, well, we'll find out.
Not always, apparently.
But it's a huge 1,600 patient trial, and data not anytime soon. But I think obviously it's the next big trial from a triplet standpoint.
I worry, that study gonna be the death of everything called biomarker in renal cell cancer. Pembrolizumab, if the response rate is, replicated, pembrolizumab response rate is 71%. You're adding an active drug that we think will do better earlier. Are you at 90% now? What biomarker, especially if it ends up being durable with Mike's
We're going to have to stop, but David wants the last word.
To me, the question for us as a field, not just kidney, but GU cancer, is cui bono, right? So who benefits? So who benefits when we say things like we can't do biomarkers? Who benefits when we say we have to continue the drugs forever? Not the patients. Okay? So let's agree as a field to consider things like stopping therapies in deep responses, like EV Pembro, poor Hemplo, right? Let's do that.
What is going on up here?
What?
We're going to draw a line under this. Thank you all very much for your attention.